Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 358 of our pharmacotherapy series, which majors in asthma. The next case reads, ATR, a 55-year-old woman with asthma, is well controlled on theophylline SR 300 mg twice daily, albuterol 2 puffs 4 times daily as needed, and mometasone 220 micrograms, marketed as Asthmanex, 1 inhalation at bedtime. A peak theophylline serum concentration obtained 3 months ago was 14 micrograms per milliliter. 6 months ago, on the same dose of theophylline, her serum concentration was 15 micrograms per milliliter. ATR presents with an upper respiratory tract infection, and clarithromycin 500 mg twice daily is prescribed. So my question to you reads, is this antibiotic appropriate? A large number of medications inhibit cytochrome P450, abbreviated as CYP, isoenzymes, and are capable of inhibiting the metabolism of theophylline. Because theophylline is metabolized by CYP 1A2, 3A3, and 2E1, inhibitors of these isoenzymes can cause clinically significant interactions. C-metadine, clarithromycin, and some, but not all, of the quinolone antibiotics, e.g., ciprofloxacin, are well documented to inhibit theophylline metabolism. Because numerous other drugs inhibit the metabolism of theophylline, all patients receiving this agent should be screened carefully for potential interactions. As with any drug interaction, the mechanism, time course, management, and clinical significance should be assessed before any interventions. For example, cimetidine decreases theophylline clearance within 24 hours, and this interaction should be circumvented by using another histamine H2 blocker or a proton pump inhibitor. Classic inducers, e.g., rifampin, of cytochrome P450 also affect theophylline clearance, and patients should be monitored for decreased serum concentrations. In TRA, the interaction with clarithromycin can easily be circumvented by using azithromycin, which does not affect theophylline metabolism. The next case reads, RKM is a 24-year-old African-American graduate medical student with moderate persistent asthma, which has been well controlled for 10 years with inhaled corticosteroid therapy, beclomethasone hydrofluoroalkane 80 micrograms twice daily, and albuterol as needed. Recently, he has noticed that his asthma symptoms have worsened and he is requiring his albuterol inhaler 3 or 4 times per week, which causes him to have a resting tremor and feel anxious. One of his colleagues suggests that he should inquire about an anticholinergic medication in addition to his inhaled corticosteroid. Is this appropriate? Until now, anticholinergic agents have had limited use in asthma except in the accident and emergency department and a few other rare situations. However, in a recent study of tiotropium, a long-acting once-daily anticholinergic agent, in persistent asthmatic patients poorly controlled on inhaled corticosteroid alone, researchers demonstrated that the addition of tiotropium to inhaled corticosteroid therapy was not inferior to the effects of adding salmeterol to inhaled corticosteroid therapy and was superior to doubling the inhaled steroid dose. The morning peak expiratory flow and evening peak expiratory flow were significantly higher in patients receiving tiotropium than those receiving a doubling of the inhaled corticosteroid dose. A subsequent randomized, controlled trial found that tiotropium therapy added to combination inhaled corticosteroid long-acting inhaled beta-2 agonist in suboptimally controlled adult asthma patients was superior to placebo. Although tiotropium is not identified in EPR3 as an option for persistent asthma patients, a therapeutic trial in RKM may be considered given these new data, especially given his anxiousness and tremor with the increased albuterol use. A similar response to long-acting inhaled beta-2 agonists may be seen. In 2015, Spiriva Respimat was approved for use as maintenance therapy in patients with asthma, ages above 12-year-old, who remain symptomatic, despite already receiving combination inhaled corticosteroid long-acting inhaled beta-2 agonist treatment. The next case reads, MTM is a 30-year-old woman with severe persistent asthma. Despite optimal assessment, drug therapy, environmental control, and patient education for the principles of management detailed in EPR3, she has had 2 recent hospitalizations as a result of asthma. Her allergist is considering anti-IgE therapy. My question to you reads, is MTM a good candidate for such therapy? How would it be given? MTM has a pre-treatment IgE level of 90 international units per milliliter, and she weighs 55 kilograms. Omalizumab, marketed as Sol-Air, is a humanized monoclonal anti-IgE antibody that binds to free IgE in serum. Thus, binding of IgE to high-affinity receptors on mast cells is subsequently inhibited, and the initiation of the allergic inflammatory cascade is blocked. Omalizumab is effective in reducing oral and inhaled corticosteroid dose requirements in patients with severe asthma and in reducing exacerbations. This novel therapy is administered as a 150 to 375 mg subcutaneous injection every 2 or 4 weeks. The dose and frequency of administration are based on the serum total IgE level, in international units per milliliter, and the patient's body weight. Therefore, MTM's omalizumab dose is 150 mg subcutaneously every 4 weeks. Common side effects associated with omalizumab include injection site reactions, upper respiratory tract infections, sinusitis, and headache. Less common but potentially serious adverse effects include anaphylaxis, 0.2% in post-marketing spontaneous reports, which can occur after any dose even if previous doses have been well tolerated, and 24 or more hours after administration, and the development of malignant neoplasms, 0.5% of omalizumab-treated patients compared with 0.2% in control patients. Because omalizumab is expensive and must be administered as a subcutaneous injection, it should be reserved for patients with severe asthma who are not adequately controlled with standard therapies. Despite the high cost, anti-IgE therapy might be cost-effective in selected patients with severe disease, e.g., those with frequent accident and emergency department visits and hospitalizations, because an estimated less than 5% of asthma patients, severe disease, account for greater than 50% of the dollars spent for asthma care. Because the nurse prepares the dose of omalizumab for MTM, what are some special considerations regarding administering and monitoring this drug? After reconstitution of omalizumab, the drug must be administered within 4 hours if stored at room temperature and within 8 hours when refrigerated. As a result of its viscosity, the injection may take 5 to 10 seconds. No more than 150 milligrams is injected at each site. Although the risk of anaphylaxis is rare, that is 0.2%, patients should stay in the physician's office for at least 30 minutes after injection of omalizumab and be educated regarding the signs and symptoms of anaphylaxis. After leaving the physician's office, patients should seek emergency medical treatment at the first sign of anaphylaxis. Despite the low risk of severe allergic reactions, in 2010, the manufacturer added a black box warning about the risk of anaphylaxis. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 359.